Hello, students. Here we are again to do cognitive disorders. I have my trusty teacher's assistant here. He's a very smart guy. No, it's not my wife. Let me show you my wife. Here is my wife. She didn't comb her
Funny,
hair
honey.
today.
Very funny. All right, I'm levitating out here now.
Okay. Well, anyway, back to cognitive disorders, which I think I might have one right now. No, just kidding. But anyway, before I get going here, I'd like to talk about yesterday's lecture on anxiety, which I recorded yesterday. It's very appropriate that it applies to the coronavirus issue. And one of the issues with the coronavirus is that it's ambiguity. We don't know about this virus, and I think that's what's scaring people. If we knew about the virus, we wouldn't be on quarantine because we'd know what its infectivity rate is, things like that. So once again, it's the ambiguity that makes people nervous. But anyway, let's get back to cognitive disorders. Here we go. Okay, let me get this guy out of the way. Goodbye, teaching assistant. You stay there. Good boy. Okay, so cognitive disorders are an impairment of higher executive functioning, which involves memory, learning, and problem solving. If we remember, the frontal lobe is what is involved with problem solving, learning, executive functioning, planning ahead. It is really the attribute of the human brain that is able to do that. Like I've said before, my dog does not use a clock or a calendar or anything like that. He basically regulates himself to the sun. Okay. Cognitive disorders are usually caused by organic changes such as cell damage. In other words, they can actually see cell damage in the brain of somebody with Alzheimer's disease and other cognitive disorders. But that is changing because now we realize that even in schizophrenia, there are organic changes in the brain, such as larger ventricles. Okay, the line between organic and psychiatric illnesses is decreasing as we realize psychiatric illnesses may also have organic changes. So there are basically two types of cognitive disorders. One of them is delirium. It has an abrupt onset. It is transient, impairment of consciousness, memory, and attention. In other words, the person can be clear thinking 1 minute, a few minutes later, they're confused and they go back and forth, in and out of delirium, back and forth. Okay? May appear with it and then out of it. It is usually reversible if the cause is treated. Sensory disturbances such as visual hallucinations are rather common, usually due to an underlying problem. Up to 50% of elderly in the hospital experience this. So an elderly person, when they're moved from their home environment to the hospital or a nursing home or something like that, they can adapt and they can get quite confused and they can become delirious. Another example of this is alcoholic delirium tremens. By definition, DT means delirium tremens. Okay, some of you may have seen this in clinical. I believe the Monday group has, where someone coming off alcohol, as their brain is not used to being without the alcohol, they can have the DTs. But the key feature of delirium is it is an abrupt onset and fluctuates throughout the day. You're more aware, you're less aware, you're more aware, less aware, things like that. Okay, possible causes of delirium. Liver problems. If your liver can't get rid of ammonia, which is toxic, it builds up in your blood and you can become delirious. Very high temperatures can make people delirious. Dehydration, poor oxygen sats. We know we can put a pulse ox on somebody and measure that now. Electrolyte imbalances, drug toxicities, either prescribed or abused. Again, alcohol being one, cocaine, things like that. Elderly people with infections, particularly UTI, they can cause delirium in an elderly person. If anybody works in a nursing home and they see a rapid change of consciousness with an elderly person, they immediately test for urinary tract infection. Okay, so very not uncommon to happen, cause of delirium in the elderly. The treatment of delirium, again, we have to find the cause. If we can find the cause and treat it, the delirium will usually go away on its own. Usually no treatment for delirium itself. Okay, we want to get to the underlying cause. Again, if the person is agitated, we can use an antipsychotic. In the elderly, a good medication there is Risperdal. It's an atypical antipsychotic. We want to avoid benzos because they can increase confusion. When you think of a benzodiazepine, think of alcohol. Okay, it can confuse people. Our job is to make sure these people are safe, make sure the environment is safe. We may have to use restraints. Again, that's an absolute last resort. We would probably go to mittens if they're, mittens over their hands so they can't undo things, pull out IVs, things like that. So our job is really to take care of the safety of the patient. Okay, dementia, on the other hand, this is global, affects everything. It is persistent impairment of memory, cognition, judgment, and affect. Affect being, once again, the way you prevent your mood. The primary neurotransmitter here is acetylcholine. So we can think of the memory neurotransmitter is acetylcholine. It usually has a gradual onset. Again, delirium has a rapid onset. Usually it's progressive and non-reversible. Consciousness does not fluctuate much. Alzheimer's disease is the most common type. We're seeing more Alzheimer's disease as our population lives longer. There is a disorder called pseudo dementia in the elderly. It looks like dementia, but it's not caused by dementia. It's caused by depression. So if you treat the underlying depression, you can actually get rid of the pseudo dementia, pseudo meaning fake dementia. Okay, so this type of dementia, pseudo dementia, is reversible when you treat the depression. So again, if you saw an elderly person who appears demented, you might want to try a course of antidepressants. Zoloft would be a good choice here, and see if that pseudo dementia went away. So here are the types of dementia, several types. Primary, it is caused by a disease that directly affects the brain, for example, Alzheimer's. So primary means it goes right to the brain. Secondary means it's due to an illness that started elsewhere but affected the brain. An example of this would be late-stage syphilis or Lyme's disease. Reversible, this subsides when underlying cause is treated. Irreversible, permanent brain damage. Most dementias are irreversible. So dementia is not something we would like because it's hard to treat. Let's talk about the types of irreversible dementias. Again, 90% of all the cases of dementias are irreversible. Vascular dementia used to be called multi-infarct dementia. These are mini strokes in the brain that affect memory and cognition. Okay? It actually, people with these mini strokes, it's not a major stroke where you're paralyzed. Your memory is slowly deteriorating. You can think of the equivalent if you look at an elderly person's skin. Their skin is so frail, it tears so easily, and this is what their vasculature is doing in their brain. Okay? Another type of dementia called Pick's disease is atrophy of the frontal and temporal lobes. It is similar to Alzheimer's disease. Third type here is Jacob-Creutzfeldt disease. It is the human form of mad cow disease. You may remember about maybe 10 or 15 years ago, there were bans on importing beef into the United States or to England, things like that, because they had found there were some cases of mad cow disease in cows in these countries. In fact, in wild deer, occasionally we see mad cow disease in deer. Okay? This is caused by a prion. A prion is neither a bacteria nor a virus. It's a loose piece of DNA that just floats around and jams up the nerve cells. And it is not killed by cooking, so it's rather dangerous. Huntington's chorea, this is a genetic illness, causes movement and cognitive disorders. Parkinson's disease, also a movement and cognitive disorder illness. Spoke about tertiary syphilis. This is late-stage syphilis causing dementia. Head trauma, HIV dementia, Alzheimer's. Getting back to head trauma here, now they're realizing that football players are prone to this because you can have multiple mini head traumas that you don't really feel are a problem, but over time the damage is cumulative. In fact, I believe there was a football player who committed suicide. I think his last name was Seau. and he wrote a suicide note saying, "Please dissect my brain, see what's wrong with me." Very, very sad. So head trauma in football is becoming a big deal now. Let's talk about Alzheimer's, since this is the most common type. Let me have a sip of water. Hold on. It is both primary, meaning it directly affects the brain. It is progressive and irreversible. And notice I say at this time, because right now we cannot treat it very well, if at all. Okay? The definitive diagnosis can only be made on autopsy, again, at this time. At this point, I have just heard that there might be a blood test coming out for Alzheimer's disease. We're not there yet, but we're getting close to that. So we are making progress in Alzheimer's disease. There are two types of Alzheimer's disease. Well, same disease, two types though, familial and sporadic. Alzheimer's disease involves neurofibrillary tangles and beta amyloid plaques that get developed in the brain of an Alzheimer's patient. They've also noted that there are proteins called tau proteins, and now the research is really focusing on these tau proteins as opposed to the beta amyloid plaque. So they're thinking that these tau proteins that are not wrapping themselves properly may be the underlying cause of Alzheimer's. A lot of research going on here. The familial type of Alzheimer's disease is early onset, before age 65, tends to follow inheritance patterns. In other words, it's more inheritable. And they've noticed that the possible genes involved here are genes 1, 14, and 21. Well, there's a disorder called trisomy 21, which is Down syndrome. And virtually every patient with Down syndrome, every person with Down syndrome, if they live long enough, they will eventually get Alzheimer's disease. The sporadic type is after age 65, has less of an inheritance pattern. Again, these are most cases because this is an illness of older people. Possible genes here are 21, 14, and 19. So there's a genetic component here. As I've said many times, all these disorders are a combination of genetics and the environment. Theories of causation here. Again, probably nature and nurture. Some possible environmental factors, as maybe a virus is involved here. They're not sure, because we know that viruses take a little of your DNA, give it to me to a pig, back to me. And this is what COVID-19 is a virus. And the big fear here is that it mutates and becomes more infectious. That is the fear. Another theory back about 15 or 20 years ago was aluminum, because they found aluminum deposits in the brain of Alzheimer's patients. So they thought, well, maybe aluminum is causing it. They did some studies and they found that's not true. I remember maybe 15 years ago they were saying, throw out your aluminum pots and pans, it's no good. But they've done research and that does not appear to be the cause. Head trauma can cause this also. Free radical damage affecting brain proteins. When you think of a free radical, think of the chlorine atom. We know that chlorine around a pool or salt water that has chlorine is very damaging to metals and other things. Okay? It also might be autoimmune. Again, we're not sure, but the research is going on. Well, the 4 A's of amnesia, of Alzheimer's disease, you can barely see it in the upper screen. Let me see if I can do that. There we go, the 4 A's of Alzheimer's, and probably of all dementia in reality here. Amnesia, which is a loss of memory, which is the primary symptom here. Agnosia, inability to recognize. Apraxia, inability to carry out movements. And aphasia. There are two types of aphasia. Expressive aphasia, an inability to put thoughts into words. Receptive aphasia, an inability to understand the spoken word. If anybody works in a nursing home with older people, sometimes they can't get the right word. They're trying to find the word and they can't seem to find it. what I would do in this case is give them a couple of seconds, maybe 5 or 10 seconds to find the word. But if we let them search for the word without finding it, they get frustrated. So after a few seconds, I will give them the word that I think they're looking for, okay? And this is where your judgment comes in. If we give them the answer and the word all the time, we make them feel like babies and children. We don't want to do that. But on the other hand, we don't want them to struggle trying to find this word, So we give them 5 or 10 seconds, okay? Stages of Alzheimer's. And again, different books have different stages. I think I read one book and there were 7 stages. We're going to go with our book that has 4 stages. Stage 1, mild cognitive impairment. Okay, mild amnesia, mild expressive aphasia. Patients probably still able to take care of themselves at this point. Might even seem like normal aging. But at the end of this stage, the patient can begin to realize something is wrong. And this can cause anxiety and depression. And again, what we would do here is the doctor would come in with maybe antipsychotics to calm the patient down. They can use benzodiazepines very cautiously because we do know that benzodiazepines can disinhibit the elderly. Once again, when you think of benzos, think of alcohol. Alcohol can disinhibit people. Okay? All right, stage 2, moderate amnesia increases here. Increased confusion, person's getting disoriented. Apraxia begins. Receptive aphasia begins. Poor ADLs, in other words, they're not taking care of themselves very well. They can become delusional also. These delusions many times can become paranoid. It's not uncommon for people, even elderly people without dementia, to have thoughts that people might be taking things from them. Okay? This can lead, at the end of this phase, they really begin to realize something is wrong, and they can have catastrophic emotional reactions. Yelling and screaming, realizing there's something wrong with them. Also, at the end of this stage, again, this can happen in any dementia, what's called sundowning. As the sun goes down in the sky, maybe 4 or 5 in the afternoon, this time of the year, people get more confused. Okay? They also have a loss of ability for self-care, as I said. Stage 3 here, this is the severe stage. They become frail, barely ambulatory. They need total ADLs. ADLs means activities of daily living. In other words, showering, bathing, toileting, possibly feeding. They can become incontinent. They can be more combative. And they can begin to touch and taste things that we would never think of tasting and touching. I'll leave that up to your imagination. Okay? Hold on one second. I'll be right there, everybody. Okay. Back here. Sorry about that. Okay. We did this already. Let's go to the next stage here. The end stage, stage 4. Now they're in a stupor, almost like a coma, unresponsive, non-ambulatory, infantile, contracted, non-verbal except for unrecognizable utterances. They're just kind of groaning and things like that. What's interesting here, as they contract, people's flexion muscles are stronger than their extension muscles, so they naturally contract into a fetal position. Let's talk about some risk factors for Alzheimer's disease. Certainly older age, we know that. Family history of Alzheimer's, a family history of Down syndrome also, head trauma. We also low educational level and non-exercising of intellectual brain functions. So they've noticed that people with higher education levels appear to have less Alzheimer's or less dementia. But the question is, are they able to cover it up better because they have a bigger vocabulary, things like that? We don't know. We do know that people that don't exercise their brain as they get older are more prone to dementia. Again, I've spoken about my dad quite a bit. As you know, he just passed away. And the doctor used to tell us, talk to your dad, engage your dad in conversation. They also told us that hearing loss can add to dementia, because when the person can't hear, that part of the brain kind of withers away. So it's very important for older people to have hearing aids and for us nurses to engage them. And this engagement can be done during AM care. You're talking to the patient. I remember when I worked in the VA hospital, I would ask the guy, were you in the military? Where did you serve? Did you see combat? In fact, in 1988, I nursed a man who was in World War I. That man is long deceased now. I may have been the last person to really talk to him in depth about the war. And again, I consider that a privilege to talk to people. I look at people, every human being, as a book that I want to read. And when they get older, that book is going to be closed very soon. So I want to get to read it. I like working with elderly people. I find it very, very rewarding. Let's talk about some stories of dementia. Okay. Well, I was doing some private duty nursing in Lloyd's Neck, which is a very rich part of Huntington. This agency, the woman took me in and introduced me to this man. This man was quite wealthy. He made a lot of money during World War II. I believe he was making uniforms for the military. Anyway, he had some dementia, so I was there just to make sure. He lived on the water, so I was just there to make sure that he didn't, walk into the water off his dock, something like that. I was there for safety. And so she said, look, just kind of sit in this room and just make sure he's, peek around the corner and make sure he's safe in bed. So every 10 or 15 minutes, I'd peek around the corner. He'd be in bed. Peek around the corner. He's in bed resting. Well, at about 11 o'clock at night, I hear this bang, bang, bang at the front door. Wow. I run downstairs. I open the door, and there's a policeman. He looks at me and goes, who are you? I said, I'm the nurse. He goes, where's the homeowner? I said, the homeowner's upstairs. He goes, I'd like to speak to him right now. I got a phone call of a burglar in this house. Oh, boy. Okay, I bring the police officer upstairs. I bring him, I say, Mr. So-and-so, the police officer's here. Somebody called the police. The patient looks at me, points to me, looks at the cop and says, arrest that man. The patient thought I was a burglar. All he saw was my head peeking out from behind the corner, seeing if the patient was okay. Once the policeman realized that I was there to make sure this person was safe, he kind of gave him the nod and said, okay, no problem. Well, another story here, I like to tell stories, was working in a hospital. There is a bar in Fort Salonga now it's called Elijah Churchill's. It used to be called Squatty's. Must have been a reputable place, I'm sure. And one of the patients used to go there quite often. Well, he got admitted to the psychiatric unit, and he looks at me and goes, hey there, lad, can you pour me a beer there, lad? Of course, I said, I'm not the bartender, I'm a nurse. Oh, no, pour me a drink. Anyway, he had dementia, and he thought that I was a local bartender. Okay. Well, another story here. As you know, again, I like to tell stories here. I've been hurt 3 times in my career, which isn't too bad when you think about it. I was working in a hospital. A patient was admitted because he had dementia and he was hitting his wife. His wife came to visit him, and the head nurse said, look, just sit in the room, in the day room next to him. Make sure he doesn't hurt his wife. That's the last thing we want is his wife to get hurt here. So I'm sitting to the right of the patient, and the wife is sitting to the left of the patient. And out of the blue, he backhands me right in my nose. And that time it did bleed. So, another story. When I was in nursing school, we were doing community health, going in the community, helping elderly people, with their errands and things like that. We went to this Monsignor's house, a very high priest. We had to help him fill out some welfare paperwork. So we helped him fill out the paperwork. We're just about done. And he says, oh, please, please, I'd like to give you confession. And I said, oh, boy, I haven't been to confession in a very, very long time. Oh, my gosh. So he goes, Patricia, she was the other nursing student, please come into my altar. His front porch was turned into an altar. And let me give you confession. So I didn't listen. She gave confession. Hey, Michael, it's your turn. Oh, boy, I walk in there. I kneel down, and he says to me, I can see you're very nervous. I absolve you of all your sins. Whew, I felt so much lighter. It was wonderful. So we're ready to leave. Patty, let's go. Oh, no, no. Please, let me give you communion. Okay, Patricia, you'll go first. She goes in, she gets communion. For those of you who are Catholic, you know there's a white wafer called the host. She gets communion. Michael, it's your turn. He calls me in. I kneel down in front of him, and he looks in the chalice. The chalice is the little goblet that holds the wafer, and he cannot see it. He's panicking. I've lost the wafer. God, please forgive me. I've lost the way. He's looking everywhere. I get up. I'm looking everywhere. Patricia comes in. We're looking everywhere. Finally, I look inside the chalice, and there is the wafer right there. He couldn't see it because he couldn't see very well. That's why we were there. He gives me communion. We're ready to leave, and he goes, you're such a lovely couple. You're a beautiful young couple. Let me do one last good deed. Let me marry you. You're a beautiful young couple. Of course, we were friends, but we were not that friendly. So anyway, that little story, this priest had some dementia, this Monsignor had some dementia, and he wanted to marry me and the other nursing student. Okay, I'm trying to make this be better here. Let's try that. Okay, so let's talk about some medical treatments of Alzheimer's, and this can also be other dementias also. What we want to do, since I said we know that acetylcholine is the memory neurotransmitter, we want to find a way to increase acetylcholine. If you remember back at one of our earlier lectures, there was a medication called monoamine oxidase inhibitors. Monoamine is an enzyme in the synaptic space that breaks down neurotransmitters. Well, there's an enzyme called acetylcholine esterase that breaks down acetylcholine. If we can disable the acetylcholine esterase, it won't break down the acetylcholine as quickly, which means you'll have more acetylcholine, which means you should have a better memory. That's the way these medicines work. They are acetylcholine esterase, that's the enzyme, inhibitors, Aricept, Exelon, Reminil, Tacrin. So these medicines decrease the breakdown of acetylcholine. Again, therefore you have more acetylcholine. These medicines do not work very well. They work a little, they may slow the illness a little, but they really aren't a miracle drug. They change the course a little bit of the illness, but nothing that's significant. There's another medicine called memantine, also called Namenda. This decreases glutamate. Glutamate, I haven't mentioned it much, but it is one of the most common excitatory neurotransmitters in the brain. Okay? But they notice if you have too much glutamate can cause cell death. So what Namenda does is it decreases glutamate, therefore decreasing cell death. But again, we're not getting robust responses with these medicines. They just don't work like we'd like them to. Okay, let's talk about some side effects. You can barely see it up there. Side effects of acetylcholine esterase inhibitors. Okay, acetylcholine esterase inhibitors increase acetylcholine by binding to acetylcholine esterase, thus preventing its breakdown. I spoke about this. They increase the parasympathetic nervous system and decrease the sympathetic, because if you remember, acetylcholine is also the primary neurotransmitter for the parasympathetic nervous system. You also should remember that adrenaline is the neurotransmitter for the sympathetic nervous system. Okay, so what can happen? Here's some side effects of these medicines. Headache, diarrhea, nausea and vomiting, urinary frequency, hot flashes. This is caused by an increase in the parasympathetic nervous system. Okay, just a sidebar here. Acetylcholine esterase inhibitors were used during World War I. They were nerve gas. So when they lobbed this nerve gas canister, it would prevent the breakdown of acetylcholine, and acetylcholine also is the neurotransmitter at the neuromuscular junction So the soldiers would literally twitch, vomit, diarrhea until they died. Very, very cruel death. Very cruel. So meds that can control the symptoms. Again, benzodiazepines can be used here very cautiously because they can disinhibit, but it's worth a try. They decrease anxiety. They can decrease aggression. We can use antipsychotics. Risperdal is a big one with the elderly. They can decrease aggression also and some paranoia. We can use antidepressants to increase their mood. It's not really going to help so much with the dementia itself, but it can increase their mood and decrease their anxiety. And the drug of choice here would probably be Zoloft or Lexapro. Prozac is a little too powerful here. Okay, as a general rule, atypical antipsychotics are preferred. They have way less side effects than the typical ones. Remember, the typical antipsychotics are Haldol, Thorazine, Fluvenazine, Mellaril, things like that. The atypicals are Clozaril is the big one. And once again, remember Clozaril can cause agranulocytosis. That's the big side effect. That's why it's not a first-line medication. It is the best antipsychotic, but not first line because it can decrease your white blood cell count, which makes you can get sick more easily because you don't have any cells to fight off infection. Okay, so let's see. So again, the atypicals, Risperdal is a big one used here. We want to avoid tricyclic antidepressants and other meds with high anticholinergic activity. Again, remember, can't see, can't pee, can't spit, can't. You can fill in the last word. Okay. Zoloft over Prozac in terms of SSRIs, like I said. We want to avoid meds that can cause confusion, anticholinergic or orthostatic hypotension side effects. Again, orthostatic hypotension, when people stand up quickly, they can get lightheaded and dizzy. A nursing intervention we do here is have the person sit up in bed and dangle at the bedside for maybe 15, 30 seconds or maybe a minute. I've done this with patients. I sit them up in bed. I let them sit there for maybe 30 seconds. How do you feel? Do you feel lightheaded? No, I don't. Okay, let's get up. Okay. With all meds, if drugs are equally effective, we're going to use meds with less side effects. We're also going to use meds with a shorter half-life. One, if the person has a bad reaction, it comes out of their system more quickly. Also, when people get older, their liver does not work as well. The liver is what gets rid of drugs in our body. Most of them, not all of them. If the liver's not working well, the drugs will have a longer half-life. So if you use a drug like Prozac, which has a very, very long half-life, you give it to an elderly person, they can have an effect 2 months down the road. So we want to use Zoloft, which has a shorter half-life. Of course, with a shorter half-life drug, we have to administer that medication more often. So half-life involves dosing. A shorter half-life, you have to dose more often. Also, a shorter half-life drug tends to be more addictive. That's why alcohol is highly addictive. It has a short half-life. Let's talk about reversible dementias, only about 10% of the cases. Pernicious anemia, this is a B12 deficiency. You give them B12 and their dementia resolves. Normal pressure hydrocephalus can also be reversed. I'm not sure how, but you can treat it. If you can get the chemicals and the meds out of the patient, they'll get rid of the dementia. In terms of substance abuse, alcohol is probably the only drug that can cause both delirium and dementia, especially in untreated withdrawal. So in withdrawal, somebody can become delirious, right? Delirium tremens, and chronic use of high-dose alcohol, it can actually kill brain cells. Again, one example of this is when we give an injection, an IM or a sub-Q injection, we clean your skin with alcohol. Alcohol kills germs. If it kills germs, it kills our brain cells and body cells, of course, at much higher doses. Okay, there's another type of disorders here called amnesic disorders. These only involve memory impairment as the primary symptom, do not have the forays of dementia. This can be either transient or chronic. Possible cause could be head trauma, again, alcohol abuse, hypoxia. A good example of this is alcoholic blackouts. If somebody drinks a lot of alcohol, We've spoken about this when we had the drug addiction lecture. Their body is fully awake, but they have zero memory. So they wake up the next morning and they forget what they did last night. And they go to their friend's house, and the friend says something like, "You were so funny last night." And you say, "I was? I don't recall that." Or maybe you wake up next to somebody and you don't even know how you met them last night. Okay, that's a blackout. Blackouts occur when you raise GABA so high, alcohol does that, and benzodiazepines can do that also. Okay, also Korsakoff syndrome. You might remember that when with the addiction lecture, Wernicke-Korsakoff syndrome. Okay, so those are causes of amnesic disorders. Let's talk some common tests for cognitive impairment. Okay, so we can measure people's cognitive ability. One basic assessment is a psychiatric assessment where the psychiatrist asks you questions about memory, where you lived, who was president in 1964, John F. Kennedy, obviously. So he can assess your memory by asking you questions. There's another test called the Folstein Mini Mental Exam. This involves questions regarding place, word registration, serial sevens. We know what serial sevens is. It's 100 minus 7, 93, 93 minus 7, so on and so forth. It's actually used on the CEWA protocol form, if you remember from the addiction lecture. Okay. It also involves object recognition, comprehension, reading, writing, and drawing. It actually gives you a numerical score, so you could administer the Folstein Mini Mental, treat somebody with Aricept for maybe a month or two, give them the test, and see if they've improved. But again, for the most part, there is not a great response to these medications. There's also a dementia severity rating scale. This is a test that assesses someone's ability to function at home. And again, there are lots of these tests, okay? Let's talk about nursing process for cognitive disorders. Assessment. We probably have to get information from the family because the client, the patient, is going to be a poor historian because he has some either delirium or dementia going on here. And we'd want to ask the family, what was the course of the illness? What was the onset? Was it a rapid onset, probably delirium, or did it happen over months and years, probably dementia? Another thing we want to look at is the person on any new medication? So once again, you want to look at the last variable that changed. Oh, my dad started getting very confused yesterday. We don't know what's going on. When did he start on this med and this med? Well, he started on those meds 3 days ago. It's probably those medications, okay? Drug and alcohol use, okay, because we know that alcohol and drugs can cause confusion. We can also look at the LIP, Licensed Independent Professional, and I write that on purpose because that's a nurse practitioner, an RN, or an MD. It's not truly a physician's assistant, although PAs do great work, but I'm making a difference here. Differentiation. Okay, so we can read their results of their assessment. We can apply a nursing assessment. And again, we can apply these tests I just spoke about on the previous slide. Okay, when you administer these tests, it's very important that you administer these tests in a quiet, non-threatening environment because you're not going to get good results if the environment is noisy. Just like I would never give you an exam when I had, like I said, I like Led Zeppelin, and I would never have Led Zeppelin blasting in the room, Whole Lot of Love song, for example, while you're trying to take your exam. We're not going to get good results. So it's very important if we're going to administer these tests that the person's in a quiet, calm environment. Some nursing diagnoses here, okay? Self-care deficits mean they can't take care of themselves. They can't shower, toileting, things like that. Wandering, these people can wander. Acute or chronic confusion. Anticipatory grieving, where they're grieving the loss of their cognitive ability. And this also applies to family members. You're literally seeing your parent who took care of you go down and become less alert, less aware, less able to process the environment around them. It's very, very difficult to watch. Impaired memory, disturbed thought processes. That really means hallucinations. You can have caregiver role strain, where the caregiver simply can't do it anymore. Okay? And there's no blame there. That's why we have nurses, right? We go to work for 8 or 12 hours, we do our work, and we can come home and get some relief from it. But imagine being the wife of a husband with Alzheimer's, and you're trying to do the best you can, but you can never leave this person alone because they might fall. So caregiver role strain. And again, depending upon the symptoms you see, there could be many other diagnoses. Okay, so nursing interventions in general. Well, again, people get admitted to nursing homes, assisted livings for safety reasons. Okay, we are there to keep people safe. We want to assess the environment for potential hazards. Okay, this is very similar to working with a child, a toddler, where that you have to look around the house. What can this toddler put in their mouth? Are all the electrical sockets, covered up? Or are there anything that they could fall over, things like that? We want to interact in a calm, friendly manner. Okay. If you are rushed, they will become agitated. So it's very important that we go in and we're very calm. We can apply psych tests as prescribed to achieve a baseline, like I had said a few slides ago. We certainly want to assist with ADLs as needed. Again, we want to encourage the person to do as much as possible. When we do everything for patients, we take away their dignity. So your job as nurses is to figure out what are they capable of and what do I have to do for them. If they can do it themselves, we want them to. One, it makes people feel good. It keeps them active in their own care. And if we do it for them, we make them feel like children, which we don't want to do. We take away their dignity. Okay? We want to give, when we're caring for these patients, we want to give them choices. It's not yes or no choice, do or you don't want to do this. Basically, it would be something like, Mr. So-and-so, do you want to wear your green pants today or your brown pants today? You're going to wear pants, right? But which color? So we give them the ability to choose. That gives them dignity. Okay. We give patient choices. What would you like to wear today? Again, we don't want to infantilize them. We don't want to make them feel like babies. Let me see if I can get this better. Oh, okay, that one's there. Okay. We want to provide orientation. If anybody works in a nursing home or an assisted living, usually there's a big calendar somewhere with a clock where they're oriented to the date, to the season. Or maybe there's a current events group. Okay. We want to focus on feelings, not facts. The fact is they have dementia, but we don't want to focus on that. We want to focus on their feelings. Mr. So-and-so, you think somebody stole from you today. Nobody stole from you. You're very safe here. Your stuff is safe here. Nobody's going to steal from you. So we want to focus on their feelings. We want to provide routine and structure. They sit in the same place every day in the dining area. Maybe the shower is the same day, hopefully with the same caregiver. Okay. Meds at the same time, same room, same seating. We want to break down tasks into smaller components. We wouldn't say, here are your clothes, just get dressed. We would say, Mr. So-and-so, you pick the green pants. Why don't you put these on and I'll be right back. Of course, you're going to go down the hall and you're going to help another patient get help and then come back to this patient and help them put their shirt on. Okay? Or we want to provide stimulation that is within the patient's cognitive level. If you provide stimulation that's too high, they're going to get frustrated. If you provide stimulation that's too low, you're going to take away their dignity. So once again, your job is, what can they do? And let me give them a task that they can accomplish. We want to provide stimulation. Again, we spoke about that. Excessive stimulation can cause frustration, so we want to keep noise and confusion to a minimum. We want to praise their successes. Oh, Mr. So-and-so, you put your pants on, wonderful. Why don't you put your shirt on? I'll be right back. Okay? Again, if they can't get dressed or they can't put their shirt on, we're going to help them with that. We want to never talk in front of the patient as if the patient was not there. Okay, one of the last senses to go is hearing. People have been under anesthesia and have woken up and said, I know what you said about me, doctor. I heard you talking about me. So the last sense to go is hearing. They can hear, and they probably can still process to some degree also. Like I said earlier, we never want to show frustration. When we're rushed, when we're frustrated, that comes across in our care, and they become more agitated and resistant. We have to come in calm, cool, and friendly. We can handle this. No big deal, Mr. So-and-so. We want to have a positive attitude. Family interventions. We want to educate the family about the illness. This is not their fault. It's not something they did. Okay? We want to refer to resources that can assist the family. Social workers, abbreviated SW, are experts on what's available in the community. Respite care is a service that's offered. I know the VA in Northport offers that. If you have a veteran father or mother, you can bring them there and they'll take care of your loved one for, I think, up to 2 weeks. Well, you maybe want to go on vacation, or maybe you just need a break for a while. There are support groups. Okay? Allow and expect the family to ventilate anger, and we may be the target. Again, when you see your father or your mother going down and losing their cognitive ability, these are people that raised you, and now they're more or less becoming children. That's very difficult to watch. I can attest to that in person as I went through it over the last several years. And the family can get upset and they can project that anger onto the nurses. Do not take that personally. They are grieving. In fact, in some way, you could look at it and say, they feel so relaxed around me. I'm almost a family member. They feel free enough to talk about their emotions and vent their emotions. Hold on 1 second. Okay. Okay. My wife's picking up some dinner. Thank goodness. Okay. So again, I'm not saying accept abuse. We're not here to accept abuse, but realize people are seeing their loved ones deteriorate. It's very, very hard to see that. So remember they're grieving, and you may be the target of some of that frustration. Communication tips. We're always going to identify ourselves by our name. Hi, my name is Mike. I'm your nurse today, Mr. So-and-so. How are you doing today? We always want to use the person's surname, Mr. So-and-so. We don't say honey. Now, if the person says, you can call me honey or you can call me Ralph or whatever, that's fine. But we start out with their proper surname. We want to communicate in simple words and sentences. Remember, they're having difficulty processing things. We want to communicate one task at a time. Speak slowly and softly. Our tone should be supportive. We want to give them some time to comprehend things. Again, we give them maybe, 10, 15 seconds, maybe 20 seconds. If they can't or not responding, we want to rephrase what we said. Repeat as needed. We want to use nonverbal communication skills such as pointing and touching. Again, remember, communication involves words, but it also involves eye contact, facial expressions, pointing, things like that. Tips to prevent wandering. If people are wandering, we want to allow them to exhaust their energy during the day. There should be some type of exercise groups where they can get some exercise. We want to keep the patient occupied by involving the patient in daily activities and their own care. Maybe they can fold laundry. Maybe they can help us make beds. Maybe they can hand out trays under supervision. Of course, we're not going to let them do it on their own. We're going to make sure we're supervising them. We want to have scheduled walks and exercise, activities and games. Again, rec therapy will probably get involved with this, but we should be bringing our patients down to them. We want to use sensory alarms on doors. Okay, I had worked in a hospital at one time, and we got a phone call from Walt Whitman Mall Security. and they said, "Are you missing a patient?" And we said, "No, we're not missing a patient. No, we're not missing a patient. Well, we have a man here in green pajamas carrying a bag that looks like it has urine in it." And we were like, "Can you just read the tag on his left arm?" Well, they read it to us, and lo and behold, it was one of our patients. We said, "Please keep him there. We'll be right there." We zoomed up, got him back to the hospital. Don't ask me how you get on a bus in green pajamas carrying a bag full of urine with no money. I don't know where the bus driver was, but we won't ask those questions. Okay. Well, once we got that patient back, of course, we had to report it to administration because that's quite a big blunder. And our request to solve the problem was we need combination locks on the door. Administration did that, and the combination was 1, 2, 3, 4, 5, 6. Now, if you're demented, that would be hard to do, right? But for us regular folks, it was quite easy. You probably want to inform neighbors and police if you have a person with dementia at home and you're taking care of them in the community at their home. You probably want to tell the neighbors and the police, because if they see this person walking down the street, at least they know where that person belongs. Non-medical treatments. Again, we spoke about this a little bit. Reality orientation. There should be a calendar, a large clock, a weather board, name and picture maybe on the door of the patient. And this picture is not when they're 90 years old. I know when I worked in the VA, the nursing home, there were pictures of the guys when they were 25 in their military uniforms during World War II. Because none of us think of ourselves as 90 years old. As I've told you guys, my brain feels like I'm 30. Of course, I'm not, but I don't see myself as 60. It doesn't register. Most people that are 90 don't see themselves as 90. Okay? When they go into these assisted livings or nursing homes, nowadays they let the people bring in some personal possessions. In yesteryear, these nursing homes were very austere, and the beds and the furniture was kind of institutional. And now they let you bring in items from home. My grandmother loved opera, so she brought in her phonograph. Again, phonograph plays records, if you know what they are. Okay, and she brought in her record collection. They want to do that, bring things from home. You want to have groups on current events, groups where people can discuss things and talk, because we know that talking to other humans, not only do we know we're very social, but also it stimulates the brain. It can slow dementia. Being engaged and talking can slow dementia. Also, what we can do is what's called reminiscence therapy. The patient is encouraged to review his life or her life and see meaning in it. Again, I know when I work with veterans, I'd ask them, you were in the military. Where did you serve? Did you see combat? Okay. It can be run as a group or individually. We can do it during AM care. So this does not have to be formal. It can just, you're bathing somebody and you talk to them. That's a good nurse, engaging the patient. Allow the patient to tell their story of their life, their childhood, their marriage, the military, work, and life lessons. The nurse may have to use reframing or other cognitive techniques to help the patient see positive side of negative events. So they may say something that they feel bad about, and maybe we can find a way that they can view it differently so they can feel better about it. The goal here is not learning, but meaning, that their life had meaning. Even if they did things that weren't quite up to snuff, so to speak, we try to have them see meaning in that. Conclusion. Again, the goal of nursing care is to maintain patients' sense of dignity and assist in preventing further cognitive decline. Working with demented patients is probably the most difficult area of nursing, as it requires constant physical, psychological, and safety assessment with a patient that will usually have a downward prognosis. In other words, these patients don't usually get well and leave the hospital. Okay, they leave the hospital, but not well, if you know what I mean. So, when you work on a psychiatric unit or you work on an orthopedic unit, you see the patient get well, they thank you, you feel like you're a great nurse. But when you're working with older patients, that's not the course of the illness. So you might not get the reward of seeing them get well. But what we do get a reward from is the family. When the family comes in and says something like, "I'm so glad it's you taking care of my dad today." That's the reward we get, that we're giving good care. Okay? We must do this all with a smile, nurturing, and compassion. So once again, this is quite a difficult area to work in nursing because we don't see the results of people getting well. But again, you see the family and they're happy that you're taking care of their dad. All right, so be posted. I'll try to do one of these every day or so. You guys keep up with it, please. I think you got a letter saying that the test will be, all of the testing for the semester will be at the last week of the semester, unless, of course, they find a cure for this COVID-19. I don't think so, but maybe. You never know. So please keep up with your studies. Do not procrastinate. I think you guys know you just can't do that. All right? You guys have a good day, and look on the YouTube for new videos that'll be coming up shortly. Okay, how do I turn this thing off? Okay, it doesn't want to stop. How do I do this? Andrew, are you there? Help me. Stop taking video. I did, but it's still running. Why is it still running here? Well, I don't know what's going on here, folks, but it looks like it's still recording. Well, maybe it's this one.